afternoon, everybody. My name is Melanie Escher, and I'm with the Arizona Telemedicine Program, and you have joined us for the Arizona Telemedicine webinar series. So we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. And again, welcome to our program today. So as you joined the webinar, your phone or your computer microphone was muted. Time will be reserved for questions and answers at the end. Please use the chat function to ask your questions. There's also a post-webinar evaluation for our physicians. There's CME credit during the live presentation, and the code will be in the evaluation. For all of our EMS folks, I will be able to produce a certificate of participation for you as well. This is being recorded and it will be accessible on our website later this afternoon, along with the handouts. So the continuing medical education, these are the outcome objectives. I'm not going to read through it. We have the accreditation statement, disclosure statement, and again, for the attendance tracking for the CMEs, the code will be found in the evaluation. And if you haven't set up your profile, don't worry about it. I will send out an email when we're done with instructions to do that if you haven't done that yet, and reminders to complete your evaluation. Standard disclaimer. And again, please be sure to check our website for upcoming webinars. And the evaluation will pop up in a window behind this the Zoom window that you're in, and you can fill it out. I will also send it out in the thank you email when we're done. I get to introduce Larry York. This is the Envenomations, Intoxications, and Travel-Related Diseases, more common than you think, and what to do. So Larry, I'm going to go ahead and pass the mic over to you. First, we'll get the camera over on you.
Oh, goodness. I'm ready. All right, so my name is Larry. So if you're joining us for the first time, this is our lecture series on unique infectious diseases. Thank you. Poisonings and envenomations of the Southwest. We've got probably around 14 different hours set up for you coming down the road. This is our third one already. Goodness, it's going fast. So if you haven't joined us before, we do have a few of these posted. You can go back and look at them. Hopefully they will be posted, I think, right after the session. So let me go ahead and skip ahead here. So we've got plenty of interesting topics prepared for you. And we are joined today by a couple of experts. So you might remember Dr. Norm Beatty if you were here the last time. We've also got Dr. Jeff Smelsky here to talk about something I think very exciting from both of these fellows that we're getting ready to get into some interesting times this summer with. But if you don't like the webinar, then I do have Dr. Klotz and Dr. Mazda Shirazi here who are just as guilty of as I am. So I can't take full credit there. But with that said, let me go ahead and flip over here. All right. And let's get our first one loaded. All right, so let me turn it over to Dr. Smelsky. Tell us a little bit about yourself, some interesting stuff you're doing, and let's get into it.
All right. Well, thanks for the introduction, Larry. So again, I'm Jeff Smelsky. I'm the Clinical Education Director of the Poison Center here in Tucson, Arizona. And so I oversee a lot of the education we do internally as well as externally as far as our toxicology fellowship. We have pharmacists and physician fellows coming to train to become toxicologists. We do a lot of epidemiology stuff, and rattlesnakes tend to be rather near and dear to our hearts, so to speak. And so we do a lot of research and education with regards to them. So for today's talk, I was asked to provide a bunch of information around the circumstances by which people become envenomated, kind of what's going on. So I'm going to cover a lot of that from the West Coast side of things, what we see here. And then I'm going to kind of pass the torch over to Norm, who's going to share some of the East Coast sides of things. And he's going to touch a little bit more onto the kind of basics about care and stuff, but we're not going to go very far into that today. So let's just kind of dive right on in. So I can't do any talks without throwing in some shameless plugs for the Poison Center. I'm pretty sure it's in my contract somewhere. So as far as who we are, we're one of the branches of the government. So we're under the Department of Health. Not everyone's necessarily aware of that. And so we provide this free service 24/7, 365, where people can call us when things happen that aren't supposed to happen. People get exposed to something. Envenomations are one of those things where people get exposed and they don't want to. But there's a lot of us, we do a lot of different things. We wear a lot of different hats. And so we do epidemiology-based research as well as clinical bedside assessment, including some RCTs and such. So just a little bit of a quick background on us. And when it comes to snake bites, we're a bit proud of this, so bear with me on that one. But, you know, if you look at how much is actually in the published literature with regards to snake bites. So if you take all the phase 2 and all the phase 3 studies for Crofab and Anavit, both of the current FDA approved antivenoms, it's this whopping total of 156 patients. I have personally reviewed a painful 4,500 rattlesnake envenomation calls at this point in these continuing efforts of a whole bunch of different studies that we have going on. So there's a lot of stuff that I'll talk about. You may or may not be able to Dr. Google your way to finding things that match it, but there's a big reason as to why there's so much misinformation and there's so little good reliable information out there. So we just try and give folks a perspective of how little is out there and kind of where we're coming from specifically. Last plug from us is we do have this monthly newsletter entirely dedicated to Envenomations. So I'm the editor for it. So again, shameless plug, sorry guys. But we put it out and we try and address a lot of topics that are difficult to answer because again, you're not going to find a study telling you what to do to guide things. You just have to make a decision a lot of times. So, you know, some of the more controversial topics we've touched on are like, if you have a patient that's breastfeeding, when do you tell them that they can resume breastfeeding? If you have, you know, a patient that's bleeding, like when do they need to be transfused? When can you give an NSAID again? And there's a lot of these things that have come up over the years and we've had to think it through and come up with rational decisions. And so we share a lot of our thoughts on these things that are a bit more controversial. So again, last shameless plug, you can find us there on our website. Then I'll throw in some pictures because everyone loves some pictures. So these are a couple of our kind of usual suspects. So we kind of suspect that a little over half of the bites we get consulted on are probably the Western Diamondback. Number 2 offender is probably the Mojave rattlesnake. And together they probably make up somewhere between 80 and 90% of the bites that we see. There's a bunch of other species out there, these kind of subspecies, and we suspect they kind of make up the remainder of it. They're usually a little bit harder to find, usually have to be up in particular higher elevations, and you're more likely to be kind of intentionally looking for one than kind of accidentally encountering one. But again, we have, I think, 13 to 16, depending on what biologist and what year it is, you're asking how many subspecies there are, but more than any other state in the country. How do you know that it's a rattlesnake? So we'll touch on this stuff for the biology folks. You know, you've got this triangular head, these elliptical pupils, the heat sensing pits, these big fangs that look like a vampire, the forked tongue and the rattle. And the reality is that if you can see any of these things other than the rattle, you are too close to the snake. This is not how you ID it. It's got a rattle, it's a rattlesnake. It's very unlikely that you're going to have a rattlesnake without a rattle. It would have had to have been manually ripped off by some type of mechanical injury and also not killed the snake. Also very unlikely. So this stuff is there, it's accurate, and a lot of people like to get focused on it, but really just look for a rattle at the end of the snake and you can tell. And then we're going to start to touch on some of the things people may have heard. And so there's this notion out there that this gentleman represents the typical snake bite patient. Some of you may or may not have heard of a phrase referred to as the 7 T's of snake bite risk factors. So testosterone, teenagers, tequila, intentional. There's a bunch of them. There's like 13 different T's in the 7 T's, which is kind of interesting, but essentially painting a picture of a young male intentionally interacting with a snake. And this has been out there since the early 80s. And a lot of folks to this day still think that this is the leading patient demographic. In reality, it's not even close. So it's really more likely to be grandma and grandpa. 60 plus is the majority of kind of things. If you look at by individual decades, it's the 50 to 59-year-olds that make up the leading demographic. The 20 to 29-year-olds are actually one of the smaller ones, and it actually goes down for 30-year-olds. The vast majority of people are unaware that the snake was there. So almost 84% of people were not aware of the snake. These numbers are out of a little over 4,000 encounters in 25 years. Lower extremity bites are about half. So most people just incidentally encounter a snake. They don't necessarily realize it's there until afterwards. There's a smaller portion of folks that see a snake and then make some type of life choice that arguably could have been different and then end up resulting in an envenomation. So sometimes it is indeed this 20-year-old gentleman and folks like him. It's also our grandma that went and got a broom to try and sweep the snake off her porch and then got bit while she was trying to sweep off the snake. So there's a lot of folks that fall under intentional envenomations, so to speak, or illegitimate. There's a bunch of different phrasings for it, but just meaning that they saw the snake and they didn't call a snake removal service or something else that would have been less likely for them to get bitten. Another notion that's out there is that rattlesnakes are super aggressive. I mean, look at this thing. It's enormous. It's mean looking. It's got its tongue sticking out. We already know it's got fangs in there. And I've had patients tell me that the snake chased them into their car. They had to jump through the window of their car because they didn't have time to open it because the snake was chasing it. I can't make up the stories you get from being at the bedside with rattlesnake patients in Arizona, but tangents won't do that too much. So there's certainly this notion that rattlesnakes are super aggressive, and every now and then you might need a nice one and it'll give you this warning rattle first, as opposed to just striking and attacking you out of the blue. This is incredibly inaccurate. They are, without question, ambush predators. They are very much terrified of anything the size of a human. Even a small child is going to crush a large full-grown rattlesnake by stepping on it. They don't want anything to do with us. They just want us to go away. In fact, the notion that they're rattling and hearing it is very inaccurate. They're pretty much deaf as far as how we would perceive hearing. They can hear, so to speak, through sensing vibrations in the ground, but they aren't aware that they're rattling. They're not consciously rattling. They are actually quite literally shaking because they're terrified because this big lumbering beast is walking near them that could crush them. And so if they happen to be shaking when you're near, you may or may not hear a rattle, but it's not an intentional thing they're doing to warn you. To kind of emphasize some snake behavior, we're going to watch this little video that my 5-year-old refers to as suspenseful. Let's see if I can start. So this was involving one of our patients from last year that happened to capture the event on a ring cam. For anyone that may not have located the snake yet, it's in the bottom middle of the camera. You can see it laid out straight like a stick. Dad has already walked past the snake, which is what turned on the door camera. It is actually much darker than the camera makes it appear. The camera does a really good job of making everything very bright and visualized for the sake of getting people coming to the door. And so we see the snake. Dad's already walked right past it. Snake's still just hanging out there like a stick. And we see Fido kind of walk past. And then this is where everyone starts to get super nervous. And then the daughter steps on it. And then the dog steps on it. And then it wasn't until Mom actually walked past it that the snake got scared enough to actually do something other than just lay there and wait for them to go away. So, we like to show this, one, because it makes people on edge, and two, because it really emphasizes what snake behaviors are. Again, they don't have any reason, evolutionarily speaking, to want to interact with us. And so that is very much what they do. If you live here in Arizona, you walk past them all the time and you were oblivious to it, it's better for everybody. That said, folks do get bit, and so we do a bunch of work trying to help figure out what's going on. So if you'll get life through the eyes of a rattlesnake, it's pretty simple. Big number one objective is to just avoid predators. There's a lot of stuff in the desert that wants to kill them or can accidentally kill them. The big time that they do things that are not good for survival is in the name of breeding. And so during breeding season, they go out places that they wouldn't normally go, like a lot of other species making poor choices. And sometimes they encounter humans that they don't want to encounter. We look at things that influence their behavior. Temperature is probably the big leading factor. So they're like us. If you like it outside, they do. If it's hot, they seek shelter. If it's cold, they take a big long nap. If it's warm, they lay out in the sun and get a tan, so to speak. If it's raining, they're desert animals. There's not a lot of water around, so they'll go out and drink, and they'll actually curl up and they'll lick the water off the rain off their own scales. And so again, times that humans like it outside, they like it outside. Again, they're an ambush predator, so they're just going to sit and they're going to wait for their meal to walk in front of them. They can go weeks in between meals. And so that's very much what they do. They hide, they sit, they wait, and then they live out their life kind of like that. We'll touch more on venom in a little bit, but the big function that venom needs to do for the snake to benefit is it needs to immobilize the prey in some way, shape, or form. There's a handful of different ways that it can do it, but if it doesn't immobilize prey, then it doesn't meet the needs of the snake because they can't actually swallow the food when they envenomate it. Even the rats that they like to eat out in the desert can easily damage their face to the point where after 2 or 3 rats of having eaten it, the snake would probably die from the wounds. And so they're very much a strike, release, and then they go track it down and eat it afterwards. So when do they happen? You know, what time of day, what time of year? When are these things kind of occurring where we see lots of them? And there's very specific periods. So half of the bites essentially will occur in the afternoon hours. So between 4 and 10 p.m. And a big part of this is that you have humans and snakes that need to interact. One of us being out is not enough for a bite to occur. So the evening time, especially when folks are coming home from work, time of year. So August to September is a big breeding season and mating season between the various species. So you have adults going places looking for mating. You have babies that are born looking for their own place in the world. And you have a bunch of humans that are super tired of the obnoxious heat of the Arizona summer that are finally getting some rain and going outside again. And so we kind of have this Swiss cheese where everybody's happy to go outside and enjoy Arizona wonderful nature. And then we encounter each other. And so bites do indeed occur. Now, some folks will think that a lot of bites occur for hikers and people out in the wilderness, and that's also not really what we see. A little over 60% will actually occur at someone's house. So this is either inside the house, inside the garage, or on their yard. A lot of folks get bit walking to the mailbox to go get the mail or taking the trash out, in and out of cars in the driveway. Again, the overwhelming majority of bites when you break down a bunch of different groups are at home where people aren't necessarily on guard for encountering a rattlesnake. Hikers are pretty much looking for them when they're out there, you know, and you've got big footfalls. And so, you know, your chance of encountering a snake that's scared and going to strike you while you're hiking is actually quite low. The fact that a snake may come by your house and agree that they like the environment that you're offering and decide to stick around is far more likely. So some simple tips for all folks walking around in Arizona or any snake country, because I don't want anyone to be our patients, is situational awareness. You know, don't put your hands or feet places that you can't see, because they like to hide in places where people can't see them. Folks like to keep their doors open to their house, and that's cool. I don't, because I'm terrified of snakes inside my house. It happens every year where people get bit by these giant snakes that went into their house while they had some door open. I had a gentleman last year that got bit on the hand while he was sleeping on his couch because there was a Western Diamondback under his couch in his living room. I don't want that, so I keep my doors closed. Physical barriers are the best way to prevent running into snakes where you don't want them. If you do indeed see one, this is your opportunity to not become a patient yet again, have someone remove it. A lot of folks will remove it here for free if you're in the city or kind of in the more urban areas. If you're in the more rural areas, you're probably going to have to pay to have someone remove it. There's also some venomous animal handling courses that you can take offered by a couple of different groups. So there's ways to get the snake removed that don't involve you having to pick it up or deal with it personally if it's not something you're able to do. So let's kind of talk a bit about venom and clinical effects. So this is every talk I do when I'm in person, someone says something about this to me, about how baby snakes are worse, and then some notion about how they can't control their venom. And, you know, so they just inject this massive amount of venom. And so that's why baby snakes are worse. The reality is that that's not even close to true. Venom, like most toxins, is very dose dependent. The more venom, the more bad stuff is going to happen. Little bitty snakes don't have a lot of venom. And to show that, we're going to look at an adult venom collection versus a baby. So as you can guess, the adult is on the right side and the baby is on the left. And I'm going to say that 10 times out of 10, I'd rather be bitten by a baby snake than an adult snake. But maybe that's just me. So what the heck is this stuff, right? You get this yellow amber looking liquid that comes out, and all these different things happen when you start diving into clinical symptoms. So what's going on? And that's where it gets a bit crazy. So there's a bit over 100 different toxins that may or may not be present within any individual snake. There's kind of a cluster of clinical effects that create this toxidrome of a rattlesnake envenomation. But you never know exactly what your particular offending snake is going to have. So one of the ways that we like to kind of group things is you have some enzymatic things that are going to cause a lot of like oxidative tissue damage. And so you get a lot of swelling, a lot of activation of the inflammation cascade. And then you have these very select non-enzymatic toxins that are going to kind of mess with cell signaling. Some of them go intracellular and cause problems. Some of them mimic other enzymes or other things that are floating around in circulation. So you get this host of problems that may or may not present, which makes it difficult because one rattlesnake bite is not the same as another rattlesnake bite. You can see 100 rattlesnake bites and see a whole lot of different flavors, especially when you layer on human factors and things like how much venom did they get exposed to, how much time passed before antivenom was administered. And so it's very difficult to systematically look at what's going to happen. We have a pretty good idea of everything that can happen, but very little ability to predict exactly what will happen in an individual patient at this point. So you kind of recognize that there's a bunch of different things that may or may not be present that are causing different types of dose-dependent toxicity. You can get an appreciation for where it gets complicated when you're trying to figure out exactly how, AKA severe, a particular bite may be. Speaking of that, how do you even know if you have a bite? So one of the things that tends to come up a bunch is this concept of a dry bite versus a minor bite. And so every year we see folks like this patient on the left where you've got these two little marks. The guy says he thinks he got bit by a snake. And so now what the heck do you do, right? True bites that are actually dry bites, meaning that you have an actual venomous animal that bites and strikes and the fangs, come in contact with the skin and no envenomation occurs, is actually somewhat rare compared to reported numbers. Most things reporting numbers are reporting like poison center calls and the percentage of poison center calls where antivenom was administered. There's a whole lot of reasons outside of a true dry bite where someone may call the poison center about a snake and then not actually get antivenom because it wasn't needed. And so those numbers kind of get disparate between the two groups. So I would estimate somewhere around 5-ish% or 10% based more off our numbers, as opposed to the kind of 20 to 25% that a lot of published literature might suggest, as far as kind of true bites from a known venomous animal. Minor bites is something that does indeed occur. It is incredibly not predictable, as we kind of touched on what's in venom and the different things that may or may manifest over time, because you have this depot of a toxin that's going to kind of work its way into circulation. And these new layers of toxicity kind of unfold at different time points. And so unfortunately, there's cases like this little one I'm going to talk about for a second occurring, which result in, arguably preventable outcomes. So this is a little kid, she was at a park with her dad, got bit by a snake. They recognized it as a rattlesnake. Kid was in the hospital in under an hour. Dad drove out of the park, handed off to EMS, got to an outside hospital. No one at the hospital had treated a snake bite before. They weren't familiar with it. They decided to obs to see if the envenomation got worse because they deemed it to be a minor bite. This is a practice a lot of folks still do. I'm not necessarily criticizing everyone. I'm just saying in this particular case that it didn't work out for this patient. So after about 4-ish hours, the patient rapidly decompensated. So cardiovascular collapse. She became incredibly hypotensive, tachycardic, followed by bradycardia, very non-responsive to vasopressors or fluid repletion, necessitating a very urgent transfer to somewhere that could handle a super sick, dying kid. This led to a continued delay in administering antivenom. And so a kid that went into the hospital in under an hour didn't get antivenom until about 8 hours afterwards, which is the point where I really strongly emphasize antivenom is preventative. It does not fix things that are broken. So this is kind of like watching a Tylenol exposure and waiting till they meet King's College criteria to start NAC. They're going to do the same thing as if you do it ahead of time. So here in Arizona, we're super biased about that, if you couldn't pick it up from my tone, that if there's any potential that you're going to need antivenom, there is no reason, there's no benefit in the patient in delaying it. You should just administer it. It's not cheap. We don't kind of dismiss the financial harm that comes from treating a cactus poke with antivenom by any means. But once you make that decision that an envenomation has occurred, in the patient's, risk benefit interest, it's definitely going to be better to get antivenom sooner. It arguably could also prevent cases like this that unfold. Part of the reason that antivenom doesn't fix the genie once it comes out of the bottle is that venom hijacks our own endogenous mechanisms. And so it uses our immune response to propagate tissue damage. There's a reason that tiny little drop of baby rattlesnake venom can cause tissue damage going from a toe all the way up to someone's armpits. And it's because it's like an autoimmune response kind of hijacking these pathways. Antivenom isn't going to do anything about endogenous pathways once they've been activated. And so again, there's a reason why antivenom doesn't work after it's been delayed for a period of time or where the benefits are a lot less. So Rattlesnakes are here, we just kind of have to deal with it. It's like
26.
26, okay. 3 slides left, and then I'm handing over, Norm. Trying not to be too long-winded today, sorry. I'll touch a tiny bit on pre-hospital care from our Arizona perspective. These things are out there. People have done all of them multiple times. Our simple takeaway is please don't. They pretty much all just increase tissue damage. None of them are likely to make anything better. If you're kind of restricting the flow of the venom, you know, again, you've got a digestive enzyme and toxin that's now localized to one particular area. Our best defense against the snake is we are way too big for them to eat. And so we kind of use this phrase of the solution to pollution is dilution, to quote one of our other attendings, where we really want to kind of disperse and dilute out that venom as much as possible, especially once we're in the healthcare setting. So restricting it is not going to kind of minimize morbidity, so to speak. Things like electricity from sun guns have truly indeed been studied, and we thoroughly discourage their use. Big takeaway, self-treatment, not an option. I believe that's right.
You're muted.
It looked really good though.
Oh, wow. I was talking about how much I just enjoyed being at the University of Arizona. I am here at the University of Florida, and I'm an infectious disease doctor, clinician, but I've become a resident expert in snake envenomations here. It's not uncommon for me to get a picture from one of my ED colleagues asking me to take a look at this snake picture. So what is going on here? Disconnected. 1 second, you guys. Created these beautiful slides. Can we see them?
Yes.
Okay, let's get cracking here. I think the most important thing that you can take away from this lecture, technology, there we go, is that time matters. I really want you to know that if you're concerned about snake envenomation, we shouldn't be waiting. We should go and talk to an expert and go to a hospital where we can have the level of care that's needed. Because as you saw, you know, anti-venom is really important. I think, you know, it is important as well if you're going to be, we have a lot of folks at EMS, we had some deputy sheriffs on here. I mean, I was roaming the deserts myself when I lived in Arizona, and just having just a brief understanding of what these snakes look like, I think is important. I agree that seeing a rattle, it's pretty obvious it's a rattlesnake. But some snakes do very commonly mimic rattlesnakes, and as well as sometimes you can't see that rattle, but it's always important to just get a understanding of what the color patterns may look like, and then, you know, seeing that pit viper there. In the state of Florida, we have our own set of bad boys, including the cottonmouth, which most people know, but we do have this eastern diamondback rattlesnake here. Beautiful snake, but it's got a hellacious venom, actually, that is regionally distinct in certain parts of Florida to being more toxic to humans. And that eastern coral snake there, which we have plenty of Florida. The Florida man is real. I want to tell everyone on the call that this does exist. And I grew up in Florida, traveled, lived in Arizona, and now I'm back, and I'm just like, wow, this does exist. So what do we do here? Let's say you've been called to the scene. Let's say you're one of our paramedics. You're going out to Wilcox, and you've got a snake bite. What are we doing? Well, one, you're going to chat with your patient here. Did you see the snake? Very common, because a lot of times they never saw a snake. We don't have much cacti here in Florida, but wow, I remember those cacti. And I think it's important to ask, did you see the snake? Do you have a picture of the snake? They have all these phones. Let's take a picture. Did you take a picture of it? What did it look like? Let's describe the snake. You know, let's see if it meets that criteria of concern. And what were you doing when you encountered the snake? I mean, that video is pretty classic. You know, that individual just basically stepping on the snake. I mean, that is a lot of times what we encounter is someone inadvertently engaging with the snake. And that will make sense in your history taking. Yes, I'm concerned that this could have been an inadvertent encounter and now they've been bitten. What part of the body were they bitten on? I think that's important. What were they wearing? Was clothes present? Even socks, is there any concern that it went through clothing or not? Depending on the size of the snake and the fangs present. Where did this occur? Here in this part of the world, there is a lot of water actually, and it's very common for folks to be walking their dog next to a retention pond or a body of water, and then it's not sweeping the snake away over here. It's pulling their chihuahua away from a cottonmouth, and then they're bitten. Usually a scenario that we see. And then, when did this bite occur? How long has it been? Was it 10 minutes? Was it 30 minutes? We've had folks, finally call an ambulance and it's already been an hour. I mean, time is ticking. Time is ticking. And this is important to understand when you show up to the ED with this patient. Did you rip the snake off? That's another important thing. We've had some people, they rip the snake off and now we've got a retained fang inside the body. And so this is just a picture from a hiking in the Recon Mountains. And by golly, on the left, you can barely see that snake. And it was a beautiful rock-banded rattlesnake, which did not bite anybody. But they're there to hide. They're not there to encounter you, but you encounter them most commonly. And so just some key features here we've already touched on a little bit, but what we see with looking at the snakes themselves, do they have a broad, flattened head, arrow-shaped? We've got this big venom gland sitting there sometimes, and you can see that's clearly an arrow-shaped head. That elliptical pupil does hold true here in the United States for most of our venomous snakes. When I'm in Latin America and walking through the jungles of Colombia, I'm thinking differently about the way that snakes look in Colombia versus the United States, because these characteristics don't hold true in other parts of the world. But here in the United States, this is important. And did you see that rattle? Another very important thing. And, most of the folks on this call will be educating others. I think that's important as we're encountering people in our communities. But this doesn't always hold true. There's always exceptions. Any snake expert that I talk to just always tells me to be very cautious of making these quote unquote rules, because every snake is a little bit unique. And I have just a couple examples here. That Western gopher snake, that is a very common snake to encounter in Tucson and Arizona. And it is trying to mimic maybe a Western diamondback, maybe a Mojave. And it even makes its head look a little bit arrow shaped. And a lot of these snakes are that are non-venomous are mimicking some of our venomous snakes. On the top, there's a Texas coral snake with a unique melanistic pattern. It's a rare form of that snake, but again, it does not look like a coral snake whatsoever. Here in Florida, we have these beautiful Eastern diamondbacks. They're very their behavior, they'll just kind of stroll up to your house. They'll just sit there. They don't use their rattles a lot, but their eyes are just pure black. You cannot see their pupils a lot of times. So just keep that in mind when you're talking to community members about these snakes. I bring up the coral snakes because they have a different venom profile than our crotalin vipers. And here in Florida, we have some snakes that mimic the coral snake, and they look very similar. On the right is an eastern coral snake. That's a picture from my yard. It's a beautiful snake. It does not want to bite you. It does not want to be it has nothing to do with the human being. A lot of kids will pick them up and think that they're a milk snake or scarlet king snake. And we're going to chat about that because we had a good amount of people bitten by coral snakes. One thing about it is red on yellow, kill a fellow. Everyone's heard kind of these rhymes. It does typically hold true, but you have to be very cautious again with the patterns. Some of these snakes do not always have those patterns that are consistent. And what you will see, and if you're getting too close to the snake, you will see that the color banding will circulate around the snake. And I took this from another plug, shameless plug, News from the Pit. it's an excellent resource. I'm going to be sharing this with people because Jeff has now showed me that this exists and it's fantastic. So these coral snakes are dangerous because their venom profile is different, and people have not done well when they've truly been envenomated. Why are people bitten? I think we've been talking about this. Most of the time, it's an accident. They've grabbed or stepped a snake on accident. They didn't see it sitting there. They stepped on it on accident. They were handling a snake that they didn't know was venomous. We're seeing that more commonly here in Florida than I would suggest in Arizona, because people are well educated in Arizona about snakes, and here people are very curious about them. We also see folks trying to, kill the snake, for crying out loud, which we shouldn't do, but they inadvertently are trying to rid the snake from around them. Again, the broom thing is definitely something that people do, but here it's the shovel, and they're trying to cut the head off, and they think it's dangerous, and then they end up getting bitten. And then another thing that we see again is walking the dog, very common. If it's not a cottonmouth, it's going to be an alligator. So for us, it's when I'm chatting with folks who are going to some of our parks and visiting this area, we're talking about being careful around water with their dog because they can encounter a snake like that. So pre-hospital, I think it's so important, no matter who you are and what you're doing, unless you are EMS on this call, but just call 911. Let's get started here. Why are we waiting? We shouldn't wait. In some key elements here, you want to, when you're assessing the patient, you want to make sure that you're keeping a safe distance from that snake. Is it still there? Did this person, again, did they rip the snake off? Because when we have folks coming to the ED, and we know this, they definitely can have a retained fang in there. And that would be important to know. Have them describe the snake that we were discussing. And then if able to, you could take your own picture of the snake if possible, but you really don't want to engage with the snake, obviously, and you want to get that patient to next level of care. Another important fact is you want to be calm, and you want that person to remain calm. The way that we talk to the patient, the way that we engage in that moment, they're going to be amped up, they're going to be all excited, and their heart's going to be beating 1,000,000 miles an hour. And it's important to try to get them to calm down, because that will help, again, reduce tachycardia and the movement of venom in the body, and hopefully mitigate some of those the toxic effects of antivenom in the body until we can get antivenom going. Always take a look at the wound or the site itself. Can you see puncture marks? Can you see that there is an envenomation, or at least fangs present? This is a picture from someone bitten by a cottonmouth, and I think if you're able to mark the area, make a line of demarcation, as we would say, when you show up to the scene, that's very useful because, as you enter the ED or enter the healthcare setting, you can see, is if the edema is marching, the necrosis is starting already, we can have objective evidence of this, and this can be done in the ambulance, as I would suggest, if you have a pen available. In children, and I know probably Jeff has seen a lot more than this than I have, but really tough to know when a child is bitten. They have a hard time describing a snake. They have a hard time describing the moment that they encountered the snake. What happened? Did they touch the snake? Did they pick the snake up? And most of the time, if you're concerned, like we saw in that child, we should be considering that this was a possible envenomation. And this is where, we really, when in doubt, we need to be going to the hospital and getting an assessment done. En route to the hospital, something that's been recommended, I think holds true, which is keeping the body and the extremity at a heart neutral position, laying the patient flat in a supine scenario. Let's say you're out in the desert, and you're waiting for transportation to occur. You try to find that patient laying comfortably in a supine position, helping to remain calm. And then you want to anticipate further swelling. So let's say this is a hand bite and someone has a ring on their finger. You want to remove that ring before it becomes too there's too much tension on that finger and needs to be cut off, could cause more tissue necrosis, anything like that. So, really want to see, what are they wearing? Could you remove something in that area to help allow the swelling to occur? And obviously you're going to be taking vitals, you can get an EKG at that time, because that EKG could be a baseline EKG that can be looked at the emergency department in the hospital, and it could show any change that are occurring. Heaven forbid they're already having respiratory distress, we could have supplement oxygen going. Again, this is super important, and I really want to echo Jeff and News from the Pit. That's this amazing resource. I'm going to read a lot of those articles. I read some of them in preparation for this talk, but none of this stuff works. It really, and it really actually leads to more tissue damage, and that's really important. And there's not a lot of evidence out there either. It's hard to study this, but who's gonna have a randomized controlled trial for cut and suck method? It's not going to happen. But what we do know is that once that venom enters, it's not, there's not a way for you to remove it from the body. So, those venom extractors that may exist, they are likely not an efficacious way to address this situation. And as well as tourniquets, they definitely have been shown to lead to more tissue damage. Electrotherapy, heat, and cryotherapy is not going to disrupt those venom proteins, and it's really just going to lead to more tissue damage. There is a technique that's been described mainly in Southeast Asia and Australia, where they have different venoms that are present in their snakes, and there is some controversy on whether pressure immobilization bandaging, which they call PIB, is efficacious. And in the United States, it's been recommended to not do this with our snakes because the amount of edema that's present is less than what you would see in some of, for example, a cobra in India. This has been shown to be useful in outside of the United States, but here in the United States, it's not recommended right now. And I think more research is needed. So I want to stick to evidence-based medicine. Systemic symptoms, most folks are going to have local swelling, erythema, and pain at the site. And we saw that in our study we're going to talk about quickly. And a lot of people, again, with the venoms that we see in the United States, they develop some element of a coagulopathy and thrombocytopenia. I really believe it depends on how much venom entered the body, as well as, the time at which those cascades start occurring, and when the antivenom was started can help mitigate a lot of this. But I have seen cases where antivenom started pretty quickly and they still develop pretty profound thrombocytopenia. So sometimes it really it doesn't matter as much we just need to monitor. Vomiting is something else that you can see, as well as some element of bleeding, as you would imagine, with coagulopathy. But for the most part, those are going to be your main signs and symptoms. You're definitely going to have some tachycardia. You can develop neurotoxicity with certain species of rattlesnake. And even there has been described kind of an anaphylactic type of reaction to the venom itself. But that's going to be a rare sequelae. I did find that, in Mojave, rattlesnakes are present in Arizona, obviously, but, each pit viper itself can have regional variations to their venom composition. And there's been some, in Southern California, weakness and paralysis described in Mojave rattlesnakes. Bottom right is a picture of a pygmy rattlesnake bite. Someone 6 hours after that bite, developing kind of local necrosis in that finger, and which did not need to be amputated. It actually, with antivenom, did well. Just had some chronic neuropathy afterwards. So the envenomation itself from cortland species, and those are a lot of our pit vipers. You're going to monitor vital signs, and I would suggest that they're going to be at a higher level of care in the hospital, either in an ICU setting or at least an intermediate level care. Again, we're going to remove restrictive clothes. We're going to have placement of 2 large bore IVs. You could do that en route to the hospital. but that's important to have access, vascular access. Some suggest giving a Tdap. I'm not entirely sure what's the evidence behind all that, but it's reasonable. You want to inspect the wound itself, and you can also, if there's concern for retained fang, you can do an ultrasound or an X-ray and can easily see that. We've been talking a lot about dry bites, and some feel comfortable observing patients for a time period. For the most part here, if it's a snake, either confirmed or suspected envenomation from a snake that's a venomous snake, we do give crofab, and we don't observe for dry bites, but it is also reasonable in certain situations to do that. And we'll go over that here in a second. But what's really important is getting these the blood work going: CBC, CMP, PTINR, CRP, fibrinogen or split products, D-dimer, CK. These are things that you're going to want to monitor as your patient is being treated, because obviously they can develop some of these coagulopathies pretty quickly. But we're going to give antivenom. So what is antivenom, for anybody who doesn't know? These are antibodies to antigens present in the species of snake that we see most of, the curlin, pit vipers. And how does this occur? And what are we giving these folks? So what we're actually doing is we're using enzymes to cleave these IgG antibody molecules, and we're giving them these fragments. And why do I need to know this? Well, pepsin and papain are these enzymes that help cleave those fragments, and we're giving those fragments to the human. And this is a very simple way of describing what you're giving that person. And it's been described, crofab and Antivip are the FDA-approved antivenoms, curlin snakes. But one thing that we got to always remember is these contraindications. And papaya is actually a pretty common fruit over in this part, and people who have papaya allergy, you have to be very cautious, because they could have a reaction to the antivenom itself, and it's something that we need to discuss with our patients when we're seeing them. But I think U of A, we're still giving the crofab. Is that right? Crofab or antivenom? Yes. Okay. That's what we use as well.
We're all Antivip in Arizona, actually.
Oh, really?
Yeah.
Okay. Good to know. And so how does this work? There are some differences here, and this is from Up to Date, but it's generally the recommendations on giving antivenom to folks. And we do have some those on the call who may be considering a career in emergency medicine or internal medicine. And I think it'd be good to just see this a little bit here. So the initial dose, depending on certain factors, there's a difference between the two. And what's recommended for Antivip, that'd be 10 vials with the initial exposure. And then, discussing whether or not you need more of a loading dose from there. And that's why we have Larry, okay, to help us with that. But crofab is a little bit different, anywhere from 4 to 6 vials. And then, monitoring for systemic venom effects. And then you would give more vials of crofab. And depending on how sick that person was, you could suggest giving them 8 to 12 vials in the beginning. But what I've learned is, really it's hard to know how people are going to respond to antivenom and how much antivenom, or how much venomation has occurred. And so really there's a lot of clinical judgment here with how many vials to give people. I think something else that's important is really monitoring multiple days after, their envenomation. It's something that is forgotten about out there in the medical community, and having a patient follow up to see if they're manifesting late sequelae of venomation is important. So we try to get people to come back within 2 to 3 days for the most part for drawing blood and assessing their wounds after they've even been discharged from the hospital. All right, so more about this. Hospital supportive care, pain control is important. I, clearly remember some young folks who were, in the hospital at the U of A, just and the amount of pain that they described was out of this world. And even here, we do see with the cottonmouth bites, it's just extremely painful. And, we're giving them Dilaudid, and, everyone's a bit worried about, these higher levels of pain management, but, it is pretty common for it to be painful. We do monitor for rhabdomyolysis, and fluids can be helpful in that scenario. And for the most part, with appropriate anti-venom, we're not going to see the need to give fresh frozen plasma or platelets, but I would imagine it does need to happen sometimes. But if we can get folks anti-venom as soon as possible, we see less of the need for this. The trend towards surgical debridement and fasciotomies is moving away from doing those. Hopefully Jeff agrees with this, but at least it's a clinical decision that's made with the surgeons, and oftentimes we're talking about how and when we would do that. Here in Florida, the eastern diamondback rattlesnake is really something we're seeing is a pretty dangerous snake to be bitten by in our part of the world. So we'll quickly talk about what we looked at here. We looked at 20 years of data here at our hospital, which is a catchment hospital for most of the Panhandle in North Florida, and we do have a lot of spillover from Central Florida. And we did see a wide breadth of folks being bitten, multiple counties, and as you can see, most of them were male. We had 829 confirmed snake envenomation encounters that we reviewed. And the percentage of age differ just a little bit from Arizona. We as you can see, is a pretty wide distribution of ages here of people being bitten. And I think it's just lifestyle, I'll be honest with you. A little bit of Florida man in here in some of our encounters, but we did see quite a bit of a wide range of people being bitten on age itself. What were they being bitten by? Well, the cottonmouth and the pygmy rattlesnake were their two top offenders. The cottonmouth is a large pit viper associated with water, and most of the encounters again were folks engaging in some sort of recreational water sports. That people can be bitten underwater. That does occur with this snake, and we had some of those encounters where people were walking through kind of a swampy scenario and they stepped on a snake underwater. But for the most part, these were when they were bitten by that snake, it was more of the accidental scenario, walking near water. Pygmy rattlesnakes are small. They're smaller snakes, and very much are hard to see. And most people encountered them either by picking them up and not realizing that they were a venomous snake, or stepping on them barefoot. But we had a wide variety of snake bites. 16% of our group was the eastern coral snake, which is, was more than I was anticipating. And most of those bites were people picking up the snake and not realizing it was a venomous snake, including some people who wanted to wear it around their neck and pretend it was a necklace, and were bitten on the chest. Yes, Larry, I couldn't believe what I was reading in the charts. But the same holds true with folks just being curious about snakes and wanting to pick up snakes and not realizing that they are pretty venomous. So really what I would like to focus on is kind of the symptoms of these snakes. Most people had edema, which we have been describing, depending on the species and the venom present. For example, the timber rattlesnake envenomations led to much more like CNS type symptoms and respiratory distress. People were intubated on a ventilator because of respiratory distress, things of that nature. like cardiovascular shock was again seen more with the timber rattlesnake. And there was a variation depending on the species of snake present, but we did have and we're running out of time here. So for the most part, what did we see with the Envenomations who contact with the healthcare? Quite a bit of time here, quite a bit of time. 284 minutes was the average time between the snake envenomation and the first contact with what we considered even EMS showing up. And why is that? And we're going to try to put this all together, but it was very interesting to see, how it was described in the charts. A lot of people just weren't convinced that they were bitten by a rattlesnake, or and they just were delaying their own care before going to a healthcare facility. And then, another additional between the first administration of antivenom was another 253 minutes. That's just too long. That's just too long. And there's a lot of education that's happening around here about snake envenomation. So I would tell you that Jeff is freaking out right now, but yeah, we're doing our best here to help the community and our providers understand the importance of antivenom. Other than that, we had 3 deaths in this review, and I wasn't expecting anyone to die from a rattlesnake envenomation, but we did have 2, and they were both from Eastern Diamondback, and then we had an individual pass away from anaphylaxis from antivenom. And something that is interesting, which is out of all these individuals who received antivenom, which was most of the folks in this cohort, there was 3.8% considered to have some sort of anaphylaxis or anaphylactic reaction. So that is another interesting fact that's not well versed in the literature yet. All right, we're about done here.
And we have a couple of questions, Norm. We just want to make sure we can get them covered before we
Yes,
wrap up.
there it is. We made
Dang.
it. Okay. That was moving fast.
Why don't you read them out, Larry?
All right, let me scroll up here. So we got a couple of questions here. So let me go through them one by one. Okay, so first question we have got here, do snake gators actually work? So in search and rescue, we're out where we're at risk, wondering if they're worth the cost.
So I got 2 herpetologists that I've been having collect venom across Arizona for like 5 years now, and they are convinced that genes are just as good. There are some studies that look at venom and what comes out, and then any type of barrier between the snake fang and you is not surprisingly good. But unless you're gonna have like metal plate armor, there's definitely no guarantee the snake fang can't puncture it, because those things are very sharp, pointy bone needles. And so it's not likely to be 100% effective, but severity and the things that have looked at this, again, this is an orphan disease state, have suggested that it does indeed decrease severity if you've got something. So I would say if you're concerned and you're seeing them routinely, it's only going to be helpful. If you don't feel like spending money, synthetic genes may be just as good.
All right, is that a vote for plate armor?
Or plate armor if you want to go all out, 'cause then you're good. You don't got to worry about it.
All right, next one we have got here. So this is from someone living in is that Nevada there? I can't quite see my glass. So the vet said the canine snake vaccine is only made from one type of rattlesnake, which is not in that person's particular area. So that provider actually discouraged getting the vaccine for that reason. So just a question about that discussion, I think a bit about the canine snake vaccine.
I can add something here with this. This vaccine is a toxoid vaccine created against the Western Diamondback rattlesnake. And based off of what I have heard from my veterinary colleagues is that it's really not a recommended vaccine right now because there's not a lot of evidence behind it. So that's kind of, and cross-reactivity has been shown in a mouse model, but in canines itself, it's very much understudied. And so I would say it's up for a debate currently whether it's efficacious. Jeff, any thoughts on that?
Well, in Tucson, Arizona, where the Western Diamondbacks kind of our #1 usual suspect, for the 2 vets that I've talked to about this, so keep that in mind. They have looked at it and they have found that animals that have been vaccinated ultimately end up getting less vials of antivenom. Does not, remove the need for antivenom in these cases. Especially dogs tend to get bitten in the face, head, neck area, which then can become very life-threatening from edema and airway compromise. So they've done some studies. There's like one study on like 150 dogs in Tucson, Arizona, very specifically, that has shown that this kind of relationship may exist. But again, that's a vaccine made from the snakes that the snakes are biting the dogs that are being treated by the vets here. So, the efficacy and cross-reactivity elsewhere very likely could be different and could be less, so.
All right, we got a couple quick ones. Then after what length of delay is antivenom no longer worth giving?
Such a good question.
Great question.
So I can tell you that venom levels are detectable for up to 3 to 4 weeks post an envenomation, irregardless of whether or not you receive antivenom, especially with the shorter half-life Fab antivenom. Trace levels of venom can also result in undetectable coagulopathy labs, at least in Arizona, definitively, meaning you can have an INR that's above detection, undetectable platelets, undetectable fibrinogen, and your hemoglobin is going to slowly creep downwards down to as low as 4.6 in one of our more remarkable patients. So if we see any type of abnormality, we treat it with antivenom. If it's been some amount of time and there is no abnormality, then there is no abnormality and then there's kind of nothing to treat. But if we were just going to go purely on time, when I say that I don't even need labs to know that you're okay, if it's like 3 weeks post bite, that's probably the time that I would say, like, sure, you're probably going to survive this just fine. If it's anything other than that, probably they're going to have a bunch of bruising that has been developing. And so then it kind of becomes a question of how well can they self-assess for their own bruising. The bruising is very characteristic, not located from the bite site. So it's going to be in the back and under the armpits and the groin. And depending on your body habitus and who you have helping you, you may or may not be able to visualize it. So it's a tough question with a kind of a long-winded answer, sorry. But if it's under 3 weeks, you're probably going to get sent into the ED, at least for a single set of labs in Arizona.
All right, last one. What can we do to avoid getting bitten on hikes? You're stumped. You stumped the panel.
I mean, for me, I do a lot of hiking and I think it really depends on where you are, understand kind of what the trail is that you're going to be on. Being hiking out west and now hiking here in Florida, vastly different. Some of our trails, there's grass overgrowing and there could be some water on them. I mean, you've got to really understand, where your eyes are, and keep an eye on the trail itself. Snakes are hard to see. I mean, I walk around with a snake stick sometimes, but you could have something, you're walking with some sort of walking stick that can help, that you would use in front of you. But I think it's really just being observant on the trail. I mean, that's really the most important thing. Jeff, any thoughts?
Yeah, I mean, here at least it's pretty easy to see because there's no grass and the cacti don't kind of obscure your view for the most part. So most people that are bitten while hiking are actually bit when they sit down somewhere. They'll find a spot where they want to sit down and have a snack or get some water out or something like that. And then they get bit on the hand that went down next to a snake that they didn't know was there. People actually bit like while walking on the path in Arizona is quite rare. We did have one gentleman bit while riding a bike, which seems somewhat terrifying to me, but
Wow.
as far as the like hiking and getting bit, again, it's more going to be when you stop if you don't make sure that there isn't anything around there. Snakes here tend to blend in with the rocks. And so other than that, they don't really have any cover and they're just going to wait for you to walk past. So it's not till you decide to sit on their house that they get a little bit more nervous.
All right, so that's all of our questions for today. I know we're a bit over time, but keep an eye out. We should be announcing what our next one will be. Maybe some other bites, who knows? We'll see what's coming. But thanks for everyone for joining us. Thanks, Norm. Thanks, Jeff. These were fantastic presentations. We hope you guys all come and join us probably in another month or two, okay? All right.
March 20.
Date's already in, March 20th.
We're looking at
Holy
one
cow.
for March 20th. So more information will be sent out. Please go ahead and do the evaluation and I'll be sending out an email to everybody that attended. Thank you, everyone.